This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
Thank you, everyone, for coming. It's my pleasure to be able to speak today. I'm hoping that we will be able to review some of the new advances in the treatment of breast cancer, some things that are ongoing in clinical trials, and some things that are still at the bench that we are working on here at Stanford and at many institutions throughout the United States and throughout the world. We have many investigators. This is just going to be a small flavor of what the work in breast cancer really encompasses. I've chosen to just use some case scenarios so that we can go through different strategies of managing a particular patient case, and then look at some of the new strategies as well as the old with this scenario. So the first case that I want to present is looking at the, quote, standard management of breast cancer. This is a 50-year-old local school teacher in our community who found a large mass in her left breast on self-breast examination. A mammogram done for evaluation after she was sent to her internist and confirmed the abnormality, showed a 2-centimeter spiculated mass. Ultrasound confirmed that there was an irregular abnormality in the breast on the left, and a biopsy was performed, ultrasound guided. Pathology showed there was, in fact, an invasive cancer in the left breast. The surgery and mastectomy, the approaches for surgery were reviewed with the patient, which included either mastectomy, removal of the entire breast, or a breast conservation approach, doing a lumpectomy with axillary lymph node sampling. Adjuvant chemotherapy and tamoxifen was then given. This particular scenario is going to be used and changed so that we can look at different approaches of managing this patient. This is a very complete evaluation, diagnosis, treatment that I've presented here, but let's look at some of the other approaches we could take with this patient. Suppose, for instance, that the patient 10 years earlier, when she was 40 years old, had met with her internist, had a formal review of her family history, and it was found that she had multiple family members with ovarian cancer and breast cancer, which alerted the primary care physician to then send this patient to Stanford's breast genetics group for our high-risk patients and for consideration of genetic testing. The patient then was screened because of her family pedigree and evaluation of her high risk. She was tested for the BRCA1 gene mutation, was found to have this gene mutation, and then sent for high-risk screening, which included MRI. Clinical prevention trials were initiated on this patient. She was diagnosed then with an earlier stage breast cancer, non-invasive, had not progressed to an invasive breast tumor, and this saved the patient a lot of anxiety, grief, and potential long-term problems. I'd like to just show some of the imaging studies that I've discussed. This tumor here is from the initial patient I presented who came in with a more advanced breast cancer, a 2-centimeter mass that was picked up on mammography. This is what we call a spiculated mass and what we often see on our standard mammograms. Before this was picked up, it had already become 2 centimeters in size. And you can see the abnormal features with normal breast tissue surrounding the tumor. This is some of our newer imaging modalities. Dr. Bruce Daniels leads up some of our work done here at Stanford, including screening of these high-risk patients that I just described. This is breast MRI showing the high sensitivity and the earlier diagnosis that we can make. In this particular clinical situation, the mammogram was normal. The patient has fairly dense breast tissue. You can see that there's a whitish, an opaque change, which is because of the patient's dense breast. MRI, however, done on the same patient, showed that there was actually a central lesion here. On biopsy, this was found to be a non-invasive cancer that did then not progress to an invasive cancer. It was caught early, it was removed, and this prevented the invasive disease from occurring later. This is an example of nothing was seen on the mammogram, but there was an occult malignancy seen here. Now we no longer call this an occult breast cancer because the MRI was able to actually detect the cancer. You see it here where the arrow is, and this was an early stage invasive cancer that was picked up on MRI and not on the mammogram. So that shows some of the advances that we can find using this type of imaging modality. Additional advances are that we can actually do MRI-guided biopsies. This is a vacuum-assisted biopsy. You can see the lesion shown by the arrow on the MRI here. The patient then undergoes the removal with the vacuum-assisted biopsy, and you can see at the end you have a nearly completely excised cancer. So this is some early work that's been done by Dr. Daniels' group, and I believe that this looks like a very promising method. This was in fact a non-invasive cancer that was removed by MRI guided biopsy, and this patient did not require going to surgical resection of the tumor seen there. Additional methodology being done here, Alison Kurian, and in collaboration with Dr. Daniel and Dr. Hartman, we have a joint institution with the Dana-Farber and the Stanford Medical Center, Cancer Center, doing studies for high-risk patients. There is a clinical study looking at MR galactography. In this case, the breast tissue is actually, the duct is evaluated to look for abnormal duct cells. The catheter is placed in the nipple duct, and then contrast is instilled in the duct so that you could have a better imaging of this area on the MRI. And again, we're using MRI as our imaging modality to study these patients who are at high risk for developing a malignancy. And the goal is then to try to catch this early if the patient does, in fact, develop a breast cancer. Some of the studies looking at the BRCA1, the BRCA1 gene mutation that this patient presented with show as high of a rate of invasive breast cancer developing in 85% in a patient's lifetime, 85% chance of having a breast cancer develop in their lifetime. So it could be as high as 85%. The data is somewhere between 60 and 85% from different studies that had looked at this gene mutation. So this is a very active area of research trying to prevent unneeded surgeries and to be able to diagnose these patients early. So this here now, after the gadolinium, which is the dye, is placed in the duct, we can then see that the entire duct is visualized, and it's visualized better by MRI. And here we have a three-dimensional picture which can be generated. This methodology, actually, the MRI can show a three-dimensional picture, and this can rotate so we can actually look at all aspects of the breast, if it works. So you can see that we can actually see the three-dimensional aspect of the patient's breast in order to fully visualize the duct. It's a pretty amazing technology, and there are many new methods and techniques that are being looked at for MRI, and this field is really quickly evolving. So an alternative clinical scenario then, using the same patient as our basis for the next case scenario. Again, the same patient, 50-year-old school teacher, she found a mass on her self-breast examination. A mammogram was done that revealed the abnormality. Biopsy showed a high-grade tumor with high-risk features. MRI revealed tumor then that extended to the chest wall. So the MRI was a very useful tool then to really look at the extent of the tumor three-dimensionally so that we could see that it was going to the chest wall. In this situation, recommendation was made for preoperative chemotherapy. This was initiated. The patient had, following chemotherapy, mastectomy and axillary lymph node dissection with a complete pathologic response, meaning that we know that the cancer was there initially when the surgery was done, after the chemotherapy, and prior to her surgery. The pathologist then goes and looks at the tumor specimen and does not find any evidence of residual cancer in the breast breast specimen. The patient then undergoes radiation for a 5 to 6 week course and adjuvant tamoxifen. So this is an example of what we might see on the MRI, the imaging with the tumor adjacent to the muscle on the chest wall. Making this very concerning that if we had initially gone straight to surgery, that we may not be able to completely excise that tumor and obtain negative free margins without cancer at the edges, which is what our goal is of a surgical removal of a breast cancer. So the patient then went to undergo preoperative chemotherapy. The preoperative chemotherapy, looking at the imaging, you can see that we can get a lot of information using our imaging techniques to see the response to chemotherapy. This helps us prior to initiating the surgery and also gives us information about the treatments that we're using for preoperative chemotherapy and biologic treatments. This is a very active area of research at this time. We have clinical trials which we're initiating here at Stanford, looking at biologic agents in combination with chemotherapy. Preoperative chemotherapy is rational for breast cancer. You've seen one situation here where it really helped with the management of this patient. We are able to improve breast conservation, meaning that we can preserve the patient's breast. Not in all cases, but in many cases we are able to allow patients to undergo breast conservations using this type of an approach. We are able to provide treatment up front without any delay to try to work with our high-risk patients who may have micrometastases, so there's a potential to treat this earlier. Animal studies have been able to demonstrate superior survival using this type of an approach. Patients with complete pathologic responses in clinical trials have had better survival outcomes using preoperative chemotherapy approaches. It also provides additional information on tumor responses to therapies. We may be able to incorporate targeted treatment approaches with early response data. Some of my research and my colleagues here at Stanford, we are very interested in these biologic agents that provide targeted treatments that are focused on a particular breast cancer cell and have less toxic side effects. So using targeted cancer therapies, they're selective. They target the tumor cells. There's fewer systemic toxicities. Dosing can be adjusted to the biologic activities. These are some of the benefits of this treatment approach. They may improve the quality of life during the patient's treatment, and we've seen dramatic responses in a select subset of patients. Let me give you an example of one of these approaches. Cancer cells many solid tumor cancer cells are associated with proteins on their cell surface, and the one shown here is in a family called the EGF receptor, the epidermal growth factor receptor family. We know that these proteins can be overexpressed on breast cancer cells as well as other solid tumors. There are 4 members listed here, EGF receptor 1, and HER1 is another name for this that you'll see me referring to, HER2, HER3, and HER4. And I'm sure a lot of you have heard about HER2, which is found on about 30% of breast cancer cells. So the EGF receptors, or the HER family of receptors, become activated and eventually lead to progression and signaling in the breast cancer or other cancer cell, promotes survival. You get doubling of the cancer cells in proliferation, and this is all done by this activation process shown here. The signaling pathway, the laboratory data has allowed us to elucidate many of the players that are involved in this signaling and promotion of cancer cell growth. I don't need to go into all the details, but many of them are shown here, and this has all come out of hard work in the laboratory to understand the signaling pathway so that we can better develop treatments for cancers like breast cancer. Some of the strategies which can inhibit these proteins are shown here. One strategy, which I'm going to go into some detail on, is using a monoclonal antibody, which induces an immune response. It's a direct target for the protein on the cancer cell and also activates an immune response, which then can target and kill the cancer cell. That's shown on the far left. This is an antibody that recognizes specifically this protein on the cancer cell. Shown here is a small molecule which targets the signaling pathway. It actually blocks the effect of the protein from signaling and allowing the cancer to undergo proliferation and survival. This is an inhibitor, which is another targeted approach for treating cancers like breast cancer with overexpression of these proteins. And here is shown a toxin. For instance, you can have an antibody which is linked to a toxin that then directly is recognizing the protein on the cancer cell with a toxin attached to it so that it can kill the cancer cell directly. These are just some of many approaches and many, many treatments that are being developed for cancer. One of these molecules, which we are looking at here at Stanford, is listed here as GSK 572016. We're initiating a clinical trial in the preoperative setting, combining this targeted therapy with chemotherapy. This is a small molecule that inhibits two of these proteins that are both thought to be important in breast cancer, the EGF receptor 1, which is HER1, and HER2/neu, which we know is an important molecule for breast cancer. So it actually reversibly inhibits both of these molecules. It prevents the activation of the receptor and signaling. Preclinical and clinical data support the use of this molecule in breast cancer, and clinical studies have shown responses in patients who have been treated with this agent alone and in heavily pretreated patients with advanced breast cancer. So there is a rationale for combining this with standard treatment approaches in earlier stage breast cancer. The clinical trial, which we will be opening, is a phase 2 trial. This is just the data from the trial looking at it in monotherapy and just reviewing some of the toxicities, very mild toxicities, which is one of the benefit of agents that are more targeted and biologic agents. 51 patients were in the trial, and 46.3% were progression-free at 8 weeks, and this is early follow-up. This is looking like a promising treatment approach. So the trial that we're initiating here at Stanford is preoperative or neoadjuvant. It's a phase 2 trial, and it's combining standard treatment approaches, which would be our standard of care in the preoperative setting with adriamycin, Cytoxan, and a taxane in combination with this biologic agent. The endpoints of this trial are to look at pathologic complete responses. So in other words, to determine whether or not the tumor is completely eradicated from the breast at the completion of the treatment and after surgery. And then, of course, the other endpoints are looking for clinical responses, breast conservation, radiologic responses, and being able to evaluate biologically whether or not we have changed the tumor, or to understand the tumor better, and so that we can provide better treatment approaches in the future for more women with diseases like this. We also plan to do MRI to follow the responses, as I've shown you some data to show the responses in the neoadjuvant setting previously. So moving on to another clinical scenario. This is a 50-year-old patient. Again, the same patient. She found her tumor on self-breast examination. Mammogram confirmed the abnormality. Imaging failed to identify any additional sites, so it looked like it was a localized tumor. The patient underwent breast conservation and sentinel node biopsy, which is a newer treatment approach, but is becoming more standard and is certainly the standard here at Stanford. And the patient then underwent accelerated breast radiation over 5 days. So if you remember previously, the previous clinical scenario, the patient had undergone standard radiation, which is whole breast radiation over 5 to 6 weeks. So these are some new treatment approaches in our in radiation, and our radiation group here is looking at these in clinical trials as well. The patient then had adjuvant chemotherapy plus or adjuvant tamoxifen plus or minus chemotherapy. So standard radiation treatment following lumpectomy, which is breast conservation, is an alternative to mastectomy. The patient receives local excision with tumor-free margins, as I mentioned earlier, and then undergoes 5 to 7 weeks of external beam, whole breast radiotherapy to minimize the chance of an in-breast recurrence. So some alternative approaches that are now in clinical trials here at Stanford, and Dr. Durbus, Goffinet, and Horst are actively looking at these study questions, whether or not we can treat patients with less breast tissue that is actually treated and over a shorter period of time. So some of the accelerated partial breast radiation approaches include interstitial brachytherapy, intracavitary, meaning within the tumor bed brachytherapy, accelerated external beam, which is the 5-day approach, and it's localized to the area where the tumor was localized. Treatment is completed over 5 days. Additional options for this patient are intraoperative radiotherapy, single dose delivered after the tumor's excised. So this is actually done in the operating room. So these are some very active areas of research and look very, very promising for patients to minimize side effects again and to minimize the amount of time that they are requiring treatment. Another clinical scenario, again, the patient was diagnosed with a primary invasive breast cancer, undergoes breast conserving therapy, and now looking at the fact that the patient is a node-negative, tumor-positive patient. She does receive the accelerated breast radiation and then comes into the medical oncologist to discuss additional therapies that would aid in providing this patient some insurance that she may not have a recurrence of this breast cancer. So looking at tamoxifen plus or minus chemotherapy. So breast cancer patients face some difficult decisions these days, and they always have, but there's more data to evaluate the potential treatment approaches that we have and to try to investigate what women benefit from some of these treatments that we offer. Surgery cures 60 to 70% of our patients. Chemotherapy improves survival, but not all women will benefit from chemotherapy. Most women are offered systemic treatments, either hormonal therapy, chemotherapy, or the combination of hormonal and chemotherapy. So some of the factors that we know are important and influence clinical outcome that we as medical oncologists look at to try to decide who should in fact receive additional therapy to give some insurance policy and add some clinical benefit that these patients will be free of their cancer in the long term. So the tumor size we know is important. Presence of nodal metastases is also a very important factor. The presence of distant metastases, so we always evaluate with our best techniques to look for whether or not the patient has advanced disease at the time that they present. The type of tumor that they have, the grade of the tumor, and whether or not the tumor is associated with lymphatic channels or blood vessels that may give it access to move outside of the breast. Additionally, there are other clinical factors which are important, like molecular markers, the estrogen receptor, progesterone receptor, HER2/neu, which I've mentioned briefly. I'm going to go into more detail, and the proliferative rate. So how quickly are these cells turning over and how active are they? Tells us something about how aggressive the cancer is. The patient's age is also an important factor. So we also believe that we can understand from our basic pathology a lot of these validated outcome factors that are important in clinical outcome, but we believe that the breast cancer tissue should have other pieces of information that will provide information for us to help us to assess the risk that this patient has for recurrence, and to help us to guide our treatments and our recommendations for adding additional treatments like hormonal therapy and chemotherapy. So information like, does the cancer cell possess any features that tell us it will stay confined to the breast and wouldn't metastasize? Features that would make it more likely to invade the lymphatics and blood vessels, to enter the general circulation, or to have the capacity to lodge, bring in new blood vessel supply, or grow distantly. So Dr. Jeffries here at Stanford is actively looking at some of these features at the molecular level. And I'd like to review some of the work that's being done by her laboratory and the breast cancer group here at Stanford as a whole. Why do we think the molecular classifiers are important to cancer patients? We think that it will provide information about prognosis, whether or not systemic chemotherapy is indicated, predict which systemic chemotherapy. So can we look at aspects of the cancer which will tell us whether or not adriamycin chemotherapy is of benefit over a taxane chemotherapy? So combining some of our preoperative treatment approaches and some of our molecular analysis, we hope to be able to really identify patients that need treatment, but also identify patients that will respond to a particular treatment. So this will help us guide our targeted agents and our therapeutic agents and treatments on more of a patient-specific basis, based on the biology of the tumor. We know that RNA is made from DNA and protein is made from RNA, and this is the central dogma and the approach that's used by Jeffries and others who are doing the molecular analysis. Some of the strategies to look at what we call phenotyping or profiling breast cancer cells are shown here. Genomic approaches look at the DNA and RNA level. So I'm sure that most of you have heard about microarray technology, which is a really new and intriguing area of research, and is what Dr. Jeffries is doing in her laboratory. Proteomic approaches look at overexpression of proteins on the cancer cell to be able to identify proteins that are associated with the breast cancer, potentially tumor-specific proteins, and to understand the biology of the cancer. And the function of the protein is also actively being looked at in activity-based protein profiling. So genome-wide techniques provide information about the functioning of cells in a tissue. So DNA array-based comparative genomic hybridization is one technique that's being utilized in this area of active research pursuit. And expression profiling, looking at the RNA level, again shown here by this schematic. This is just to give you an idea of how small each one of these genes is looked at. This is a penny to compare our microarray chips. To give you an idea, each one of these represents one gene on the microarray. DNA microarrays may be used to simultaneously analyze the relative expression levels of tens of thousands of genes. So on one chip, you can have tens of thousands of genes, and these can all be analyzed at the same time from one tumor. This is a kind of active slide to show the technology, but the idea here is we have on the left the control panel looking at the reference genes, and then comparing the tumor on the right panel in this microarray chip in order to determine what genes or proteins are overexpressed in each one of these tumors. This is the technology. The color scale shown here, the red is showing us that a gene is overexpressed, green is underexpressed, and the yellow shown is equally expressed, and this is relative to the reference genes. So we have a normal gene set as our reference, The controls are well established in these studies, and then we're able to analyze breast cancer cells to look at what genes are turned on and turned off so that we can better understand individual breast cancer tumor cells. This is a very impressive microarray result showing on the top what we call the dendrogram, which shows us that different tumors have a different expression profiling or a different phenotype to understand that they fall into different categories. And on the sides, these are genes that are clustered, and so we know what each one of those represents, and different gene sets that are alike fall on the axis here. Okay, and as I mentioned, the green are underexpressed genes, and the red is overexpressed genes. So some of the data that comes out of all of these studies is shown here. We are finding that breast cancer cells are in fact falling into different categories, different phenotypes. Some of the Stanford data set, and this was led by Pat Brown, David Botstein, and Stephanie Jeffries here at Stanford, have found these categories for breast cancer cells. The luminal A, which tends to be an estrogen receptor positive subtype. Luminal B, also estrogen receptor positive subtype. The basal-like, which are not associated with the estrogen receptor. And the ERB2, which is one of the EGF receptors that I mentioned, subtype, which tends to be estrogen receptor negative. And the normal breast is another category. There are other groups looking at this type of data and working together to compare the data set so that we can establish what subtypes of breast cancer there are, characterize the cancers so that we can better understand what the patient's outcome will be and what treatment strategies should be used for these subtypes. Some of this data has led to the development of a new technology which looks at individual genes. So now that we understand what genes are upregulated or downregulated or might be associated with more aggressive or less aggressive breast cancer, we can put those together and look at a smaller set of genes, unlike what you're seeing here, which is thousands of genes on one chip. Now we're looking at 21 genes. This is a recent publication which used 21 genes to try to identify who had a high risk or low risk. This is some preliminary data which I want to present here that was just recently published in the New England Journal of Medicine, which is using paraffin block previous removed tumors from a study done many, many years ago, and using that tissue to then look at whether or not we can characterize the patients that will do well and not do well. So we know the clinical outcome from that trial, and we now can go back and look at the tissue and see whether or not these genes will correctly characterize who would have had a favorable outcome and who wouldn't have. As you can see here, looking back at this data set, the disease-free survival was able to predict, using the gene set, patients who had a low risk based on the genes that were analyzed, then had a better outcome with a 6.8% 10-year recurrence rate. And patients who had a high recurrence score, which is based on these 21 gene sets, also were predicted for outcome that wasn't as favorable. So these patients had a recurrence rate of 30.5%. So this is some early data. This has only been looked at in women who have been treated with tamoxifen, who were node negative, like the patient I just presented, so sentinel node negative and estrogen receptor positive. But it is some tantalizing, interesting data that I think is moving forward and showing you that some of this work from our microarray and molecular analysis does appear to be leading to changes in our treatment approaches. This is just showing the degree disease-free survival curves, another way of representing this data. The red is patients who had a low score based on the 21 genes. and the blue was the high score, and on the y-axis we have survival. So the patients who had the low recurrence score had the best survival. So there are other approaches that evaluate for current recurrence risk. Adjuvant therapy, we've been able to establish benefit. It's well demonstrated. Some patients do not benefit, however, as I just mentioned. We need to be able to identify patients that are most likely to benefit from treatments. So circulating tumor cells are another way to look at patients who have a higher risk of a recurrence. And this is another very active area of research. We have ongoing studies here at Stanford. Dr. Carlson, Dr. Svan, and Dr. Parks have been doing trials and preclinical studies in order to try to identify patients with circulating breast cancer cells. Circulating tumor cells have been shown to be associated with increased stage of breast cancer. They've also correlated with tumor burden during treatment. They may reflect responses to treatment. And at this point, we have limited data, and this is an ongoing area of research being done here and at other centers. So the definition of a circulating tumor cell is the presence of the cell in the blood or the bone marrow. These cells have access to the systemic circulation during primary tumor development, and not all patients with circulating tumor cells will develop metastatic disease. So as I said, it's an ongoing area of research, and we hope to be able to use this information and look at the particular molecular markers on the cells, intracellularly and extracellularly, to be able to identify what is it about some of these circulating tumor cells that make them more likely to cause metastatic disease or disease that ends up in organs like the liver, the lungs, the bone. So can we detect these? Can we identify markers that identify the bad players? And some of these markers are things that will cause the cancer cell to adhere, to cause the cancer cell to proliferate. Can we identify biologically important tumor markers and find efficient methods for characterizing these cells? So why look for the tumor cells? We hope that it'll add a prognostic value, that we can be able to better inform our patients. And it also may provide us a tool to monitor responses to treatment. And characterizing circulating cells or micrometastasis, looking at markers on the cancer cells that might predict for outcomes, that might predict for responses to therapy in the same way that the microarray and DNA work that I just described could do, and markers that correlate with pathologic tumor response features. Marker patterns can correlate with the microarray findings as well. So we're fortunate here at Stanford to be able to have groups that work together. So our microarray group and Dr. Jeffries works closely with the researchers looking at the circulating tumor cells, with myself looking at the neoadjuvant approaches for treatment in order to coordinate some of these studies and try to get as much information as we can in these preclinical research models. So I don't want to go into every detail on the methodology, but just know that we're trying to develop ways to enrich for these few cells that are found in the blood system. We have beads that have antibodies that can bind to the cancer cells and to pull them out of the peripheral circulation. So if you get a blood sample from a patient, antibodies can then bind to a protein on the cancer cell, and by using a magnet, you can actually pull out the few cells that may be found in that blood sample, and in this way enrich for the tumor population so that we can study these cells in the laboratory. The antibodies that we use have a fluorescent label, and we're able to use a technology called flow cytometry, which is a specialized machine that can look specifically at the different fluorochromes or the different colors to give us information on each molecule that we're interested in studying on a breast cancer cell. The human blood samples are treated with tumor cell-specific antibodies. They're then introduced, and we're able to look at several markers on one cell at one time. The technology is called high-throughput flow cytometry. The rationale is to be able to simultaneously detect many markers on one individual tumor cell. 12 or more fluorescent markers can be looked at. That means that we could have antibodies that were specific to 12 different proteins on a cancer cell to be able to study the details of each cancer cell. And this would then be sorted and evaluated by this method called flow cytometry in order to understand better the biology of breast cancer. These are the spectra of dyes or the colors that we use for the FACS analysis, and they all fall into a different wavelength or a different range that's detected by the flow cytometry machine. And this is the method shown here, where you have the sample from a patient's blood. They're stained here with the different colors of antibodies that would bind to these cells. You can sort them in this way and end up with for instance, the breast cancer cells on the left, shown in yellow, and the other blood cells on the right. These then can be analyzed for different markers on the cell surface. They also can be cultured and saved by using this sorting approach. So that was a lot on the basic science, and these are all preclinical studies, but I want to give you a flavor of some of the research which I think will really lead to better understanding of the biology, being able to prognosticate better and tell patients more information and risk assess, as well as lead to better treatments. So our next scenario looks at a patient who had a mammogram that revealed a mass. The core biopsy was consistent with a high-grade ductal carcinoma, which is an invasive breast cancer. This was HER2/neu positive. This is the protein in the HER2 that I described earlier in the EGF receptor family that's associated with a percentage of our breast cancer cells and our breast cancer tumors. And it was an estrogen receptor and progesterone receptor negative tumor, meaning we don't think it was responsive to hormones that the patient has in their system. Staging revealed metastatic spread. So instead of being an early stage, this patient now presented with a more advanced cancer that was in the bone, liver, and lung. Local treatment and systemic treatment were initiated, and chemotherapy with a combination of trastuzumab, which is a monoclonal antibody that's specific for this HER2 protein. I think this is a very nice example of how treatments are initiated in the laboratory that are rational approaches looking at a particular target on a cancer cell and have led to treatments which have been very effective for our breast cancer patients. So I want to use this as an example of kind of going through the whole treatment, the from bench to bedside treatment. So the human epidermal growth factor receptor HER2 gene is overexpressed in 25 to 30% of metastatic breast cancer. It's an independent negative prognostic factor. It's associated with a poor outcome. It's associated with a shorter disease-free survival and shorter overall survival. This is a schematic to show you how we think that the HER2 signals. I went through some of the signaling pathways previously, but the normal cell has a small amount of this protein on its surface, whereas some of our breast cancer cells have overexpression of this protein, which then leads to excessive cellular division, proliferation, survival, and all of the things that I mentioned previously that lead to malignancy and a more aggressive tumor pathology. So the HER2 gene is a member of the epidermal growth factor receptor family, as I mentioned. There are different methods of evaluating this. Some of the earlier studies used a evaluation called immunohistochemical staining, which is again using antibody-type approaches and looking at the protein level on these breast cancer cells and the expression of the protein on the surface of the breast cancer cells. A newer approach uses fluorescent in situ hybridization, looks at the gene level, the copy number. So this is an example of the immunohistochemical staining and what it might look like on a particular patient's tumor sample. And you see a low expression of the HER2 on the left panel and a higher expression with a stronger staining on the right. So as you can tell, and I don't think that this is projecting as well as I'd like, but this is a gradation and is not a plus minus. So there can be some difficulty interpreting when a patient has an intermediate staining and knowing whether or not this represents what we would consider overexpression and a poorer prognosis in an individual patient. This is a diagram to look at the FISH testing and how you can see the normal result with the chromosome 17 centromere. This is the control, and then looking at the gene in a 1-to-1 or a less than 2 ratio. And on the right panel, you see that the gene shown here is amplified. There are more copy numbers, and this is a positive FISH result. We know from prior studies that HER2-positive patients have a lower survival, shown here. So this is a survival curve again, going up to 100%. And in the blue, we have patients who were FISH negative, who have a better outcome than patients who had the FISH positive tumor on their tumor. So the development of this monoclonal antibody, which is a targeted therapy for the HER2 protein, this is a recombinant monoclonal antibody developed to recognize the human epidermal growth factor receptor HER2. It was humanized to minimize immune response to the mouse portion, so it was initially generated in a mouse. The entire sequence of the antibody or the entire protein was of mouse origin, and then it was genetically engineered to give it a partial human portion, and only the binding portion that recognizes the HER2 is of mouse origin. This will minimize then the immune response to the mouse portion, and it maximizes the recruitment because we know of immune cells, because we know that the humanized portion of the antibody can then tell the immune system to bring in other cells from the immune system to kill this tumor, to recognize and kill the tumor. So preclinical studies with cell lines in animal models demonstrated synergy with chemotherapy and this monoclonal antibody, so potentiation of an anti-tumor effect. The potential mechanisms of action of this antibody are, number one, cytotoxic, meaning that it kills the tumor cell directly. It enhances the cytotoxic or killing properties of chemotherapy. Cytostatic, meaning that it stops tumor cell growth. It downregulates the protein. It brings the protein inside the cell so it's not overexpressed on the surface, so it can't be activated. It disrupts the signaling, which I showed you earlier. And there's also an anti-angiogenic property, which means that it disrupts the blood vessel formation on these tumors. It enhances immune responses to the tumors. This is an example of how it can enhance the immune responses, where the antibody is now on the surface recognizing the HER2 protein shown here. This recruits other cells. This is a natural killer cell, which is part of our immune system, that then comes in, and this is the humanized portion of the antibody, that the human immune cell now recognizes this portion and kills the tumor. So the structure, in order to generate this monoclonal antibody and to understand the protein, the structure of the EGF receptor molecules have been elucidated. This is all important for developing these targeted therapies. This is showing the structure of the HER2 in both rat and human and the similarities. And it also is showing the trastuzumab antibody and the molecular structure shown here. And this is actually a nice example of looking more specifically at the binding between the antibody shown on the left, we can actually look at these specific molecules that interact to understand exactly how they bind with the HER2 protein that's on the surface of the cancer cell. This is really important because some of the treatment approaches that we develop actually can be improved by just modifying the structure slightly. If we can understand the structure, we can make small modifications to make this binding and interaction better and develop even better treatments. This is some preclinical data showing that when we use the antibody in combination with other, actually this was using the antibody alone, that it arrests the tumor cell growth. That's shown on the bottom, whereas the control continues, the tumor cells continue to grow and divide. And the proof of principle was really looking at the clinical trials. This was used in first-line therapy for patients with advanced metastatic breast cancer. This was a trial that had 469 patients, received no prior chemotherapy, so this was a first-line treatment. Patients received either chemotherapy alone in this trial or chemotherapy in combination with the antibody specific for the HER2 molecule, and we found disease-free survival and median survival as well as overall survival benefit with the addition of the monoclonal antibody. Dr. Slayman and colleagues presented this work, and it was published in the New England Journal of Medicine. So this is just to provide some graphs to show you the differences in this case, time to progression. So in months, the patients had a much longer interval before they had any progression in this early trial compared to chemotherapy alone. And this is also shown on the right using a taxane in combination with the antibody. The survival had a statistically significant benefit in combination with chemotherapy, shown here, compared to chemotherapy alone. And as I mentioned, the duration of responses, I don't need to go over this in detail, but duration of responses was superior when combining the antibody with chemotherapy. Okay, so another clinical scenario, a 50-year-old local school teacher now, again, going through the same workup, instead of having a HER2 new positive tumor, she had a HER2 new negative tumor, still had metastatic breast cancer with involvement of the bone, liver, and lung. Local treatment and systemic treatment were done, and this included initiating the patient on a clinical trial, combining standard chemotherapy and another biologic agent, anti-VEGF. So vascular endothelial growth factor is another targeted therapy that we're very interested in, and we are initiating a clinical trial as a first-line therapy in combination with chemotherapy here at Stanford. The vascular endothelial growth factor is important for promoting the growth of blood vessels, the development of blood vessels for supplying the tumor, shown in this diagram. The blood vessel growth is here, and then the tumor growth is promoted because we're able to establish a blood supply for the tumor to survive. This is, again, a lot of the biology and understanding the receptor family, and there are many members of this receptor family, like there were for the EGF receptor that I discussed earlier, and many nights in the laboratory from many investigators to elucidate some of these molecules and to understand the pathways. This is a schematic to show the vascular endothelial growth factor binding to the receptor, the VEGF receptor, on the surface of a blood vessel cell, which then causes signaling and promoting the development of more of these cells and blood vessel formation for the tumor. So another strategy is to block this VEGF here using a monoclonal antibody that's specific for VEGF called bevacizumab. The development of bevacizumab, the vascular endothelial growth factor, VEGF, is produced by cancer cells. It regulates angiogenesis and new blood vessel formation. This is a humanized monoclonal antibody called bevacizumab that's against the VEGF, inhibits the growth of tumors in animals, and a survival benefit has been demonstrated in preclinical and now in clinical trials in colorectal cancer, and there's some tantalizing new data in other tumor types like breast cancer. The rationale for bevacizumab for breast cancer: angiogenesis is thought to play a role in breast cancer cell growth and invasion. There's some efficacy using bevacizumab as a single agent, and it's been shown in breast cancer trials to have benefit. Overexpression in breast cancer cells is associated with a shorter relapse and overall survival, and VEGF expression is thought to be highest in earlier stages of breast cancer. So using it up front in early treatment is a rational way to use this molecular approach and targeted therapy with a monoclonal antibody. The phase 2 trial, which we're initiating here, the rationale, again, is recent data with combination chemotherapy. First line has shown some benefit in patients with metastatic breast cancer. This was recently presented by Kathy Albane at our San Antonio breast cancer meeting in 2004. Bevacizumab plus gemcitabine resulted in a superior response rate in time to progression and survival in another clinical trial. So the combination with one of the chemotherapeutic agents has shown some benefit. By adding bevacizumab, the monoclonal antibody, to VEGF in combination with a superior chemotherapy regimen up front when patients first present with their metastatic breast cancer, we hope to obtain a better response. There are some trials looking at the combination of biologic agents using a combination of an anti-VEGF and an anti-EGF receptor biologic without chemotherapy. There's some data that has supported this. I think personally that the responses are not high enough yet to use these treatments without chemotherapy until we get to a point where we're sure we know what doses to be using and what combinations. But this particular clinical trial did show a response in combining two biologic agents. This is a CAT scan, a patient with breast cancer who had a combination of an anti-EGF receptor targeted therapy. It was one of the small molecules in combination with monoclonal antibody to VEGF. And you can see after a short period, this is the pretreatment. There's some cancer shown here and here on this CAT scan, and post-treatment you see a response, and the cancer is not shown on the post-treatment CAT scan. So in conclusion, this particular small study showed some activity in advanced breast cancer, and it had an acceptable toxicity profile. I think that more studies need to look at this, and it is tantalizing and exciting, and we will build on some of these results. So lastly, I just want to present one last case scenario. I was hoping to talk a little bit about hormonal therapy today, but I think that this is beyond the scope of this talk. But I would like to talk about some new treatment approaches. This is the same patient who was started on the phase 2 first-line clinical trial with gemcitabine, paclitaxel, and bevacizumab, is having an excellent response, but then comes into my clinic and says, I want to discuss the next treatment and what's in development. Looking forward, even though they were doing quite well, let's look and see what we can do next. So some other potential treatment approaches for breast cancer, which are earlier in development and really at the lab stage and are of a great interest to me, are immune vaccines for cancer. This is a dendritic cell shown here. This is another example of these specialized immune cells called dendritic cells. So developing methods to use immune therapy approaches which, like biologics, have a much lower side effect profile than the chemotherapy and other cytotoxic agents that are more standard for breast cancer. Immune therapy in breast cancer, I think, is a rational approach. There's evidence of immune dysregulation in breast cancer, evidence that immune responses can be generated to tumor-specific proteins. As I mentioned, HER2 is an example. Dendritic cells can be isolated from patients with breast cancer cells, and these dendritic cells, which are important immune cells, have been found to be defective. They lack critical surface molecules that we think are important in their function. They're defective in production of immune response proteins, and they're defective in generating other immune cells, T-cell responses, which are critical for recognition and destruction of tumors. So dendritic cells are professional antigen-presenting cells. They present these tumor-associated proteins or other proteins to T cells, which are immune cells that can kill the tumor. So this schematic shows a dendritic cell on the left, which is our antigen-presenting cell. It presents a protein like the HER2 or another tumor-associated protein to a T cell, which is in your body, that then is activated and triggered to respond to that protein. So you can imagine if you can activate these T cells and teach it to respond to a particular tumor-specific protein, it can then go back and this educated T cell can recognize and kill the tumor. This is just another schematic to show immune responses that are generated to kill the tumor. So these activated T cells can then go and recognize the protein that was on the surface of the cancer cell and kill the tumor. The tumor-specific antibodies can be generated using this type of an approach, which then would, like the monoclonal antibodies I described that are genetically engineered, now the patient's own immune system is able to generate these antibodies which target the cancer to eradicate it. So these are some approaches. Neurodesis is looking at using the tumor-specific protein, HER2, new as a vaccine approach in order to stimulate the immune system. This is a similar treatment approach or immune therapy approach for treating breast cancer. So this is one diagram to show you how this might work. This patient had their blood removed. Dendritic cells can be produced from the patient's own blood and generated at high numbers. And the dendritic cells can then be used for vaccination. They can be combined with targeted proteins or with tumor lysate to give it the protein and the tools and the targeted proteins to teach the patient's immune system then to respond to these tumor cells. Another approach is to introduce genes that we think that we know are critical to stimulate an immune response. CD40 ligand is one such gene. And using gene technology to introduce these into the patient's tumor. So after biopsy, the tumors can be genetically engineered to express a protein which then stimulates the immune system to be localized and recognize these tumor cells. The use of chemotherapy or radiation therapy causes cell death locally. So a patient who had a metastatic breast cancer or locally advanced breast cancer, the idea would be to initiate some treatment, cause the death of cells locally so that proteins are then released, and then you can have a direct injection of an immune cell like the dendritic cell, which picks up these proteins and generates an immune response in the local area. But this local immune response travels throughout your systemic circulation, meaning throughout your body, to teach other immune cells to eliminate the cancer in other sites. So this is some early laboratory data which I have generated using breast cancer cell lines just to show that we can, in fact, introduce some of these genes of interest, like the CD40 ligand, which stimulates the immune system. The blue shown here is the breast cancer cell lines without the CD40 ligand gene. And when the cells are genetically engineered, you can see in red that they highly overexpress this protein. This is the flow cytometry methodology. I told you earlier that we can look specifically at the expression of different proteins on the surface. So we go from not having any expression of this protein on the surface to having a high level of expression. So this is a rational methodology. We can, in fact, introduce these genes into 3 different types of breast cancer cells and have high levels of expression of our gene. This is done over a short period of time, even at 1 hour. Shown on the left panel, we start to see that the gene that's introduced into the cancer cells is expressed on the cell surface. And other genes have been looked at, which are also important for stimulating immune responses and introduced into breast cancer cell lines for evaluation of expression on the cells. And they're efficiently introduced into these cells with high levels of expression. So in conclusion, dendritic cells can be generated as a rational approach to breast cancer therapy. Immature dendritic cells can be used and directly used for treatment for breast cancer. And mature pulsed dendritic cells can also be another treatment approach for breast cancer. Breast cancer cell lines are efficiently transduced to express high levels of genes of interest. And whole tumor vaccine approaches are also a potential immunotherapy approach for breast cancer. So as I mentioned, these are all very much preclinical and laboratory studies, but these are things that are in development and we hope to be potential treatments in our future. I'm not going to go over the last, just in the interest of time. I want to be able to allow time for questions, but just you will hear many talks on the adjuvant treatment with hormonal therapy. This is a very important area of research, and we have some new exciting agents called aromatase inhibitors. Tamoxifen has been a great hormonal treatment for breast cancer for 20 to 30 years. It continues to be a very good treatment, but we have some new drugs on the horizon which have a different mechanism of action. And we hope that we'll have more such treatments and better treatments in the future. This is just looking at some of the pathways for the aromatase inhibitors, elucidating how to block the production of estrogen. And aromatase inhibitors have blocked the production in postmenopausal women. And we have some new clinical data to show a improved survival in postmenopausal women who are estrogen receptor positive using Arimidex in favor of tamoxifen. There is evidence that there is survival benefit using these new agents. This was just recently presented by Tony Howell at the San Antonio Breast Cancer meeting in December. Thank you very much. Basically, a postmenopausal patient, and you said a 70-year-old patient, but a postmenopausal patient who probably had a node-negative breast cancer, who was treated with local therapy with removal of the tumor, radiation, and followed by an aromatase inhibitor, in this case exemestane, which is an irreversible aromatase inhibitor, and one of the newer treatments for this type of disease. Then develops a lot of side effects from treatment, including fatigue, and primarily fatigue. I think that especially with radiation, and when we have radiation over 5 to 6 weeks, these patients do develop a great deal of fatigue. The aromatase inhibitor may compound that, but the process of going through the diagnosis of breast cancer, the psychosocial aspects of dealing with the new diagnosis, I think that there's a lot of things that play into the fatigue, and some of it is dealing with a new diagnosis, the physical side effects of having gone through radiation, which can be substantial. And I think I tell a lot of my patients can take up to 6 months to really feel back to normal, and if they have chemotherapy, even longer. So I try to allow a lot of support systems, guidance, and follow these patients really closely over that 6 month. And if after that period there haven't been other things identified like depression or things that we could manage, and I feel comfortable that now we're at a point where we're just looking at the treatment, I might consider changing the treatment over if they're really not tolerating it. But I think that's a hard question because these are very important treatments. We know they provide survival benefit, and I think just counseling and helping the patient get through them are what we really need to do as medical oncologists. And there are some specific side effects like arthralgias and things that we know are clearly things that we may have to alter our treatment approaches for. But fatigue's a much harder one, and just, I think, educating them on what to expect is the biggest benefit. I think fatigue is very common with radiation. Fatigue is very common with chemotherapy and radiation. And I believe that fatigue is also a component of the nature of having a new diagnosis and dealing with that. And I do find that most of my patients over time, and with good social supports in place and helping them to get support groups and giving them guidance and being sure I have frequent enough appointments that we get them through that. The question is, a patient that's high risk, how do they enter into the program here at Stanford that I discussed? So generally, the referrals for high-risk patients usually come from the oncologist, but not always. A lot of times primary care physicians pick up the high-risk patients. I think the first screening is by the primary care doctor or the medical oncologist to be sure that a patient is actually high risk. And the detailed family history is one aspect of that, and our genetics group does that over the phone to determine whether or not a patient really is high risk. As we evolve with all of this DNA technology and gene analysis, we actually now know there are many genes associated with breast cancer. So the initial screening done by the genetics group looks at these patients' total history, and it's not just ovarian cancer and breast cancer, it may be other malignancies that are found in a family and goes far out into the history and cousins and grandparents, and getting a really good family history. And so once that initial screening's done, then the testing, if it's warranted, testing is sent for more than just the BRCA1. I just use that as an example, but there are many genes now known to be associated with breast cancer that we test for. The question is that some early studies, early clinical trials with some of these targeted agents as a single agent appear to be have lower efficacy than in combination with chemotherapy and other treatments. At this point, that is true in breast cancer as well. So trastuzumab is FDA approved for breast cancer. I thought that this was a nice example to go through all of the details of how that treatment got to FDA approval. And as well as the studies you are referring to in lymphoma, we also found, and I assume you're talking about Rituxan. Yeah, Rituxan. Rituximab is another monoclonal antibody. It's to a molecule called CD20 that's on lymphoma cells. It's a very similar type of approach for lymphoma. So the combination with chemotherapy is more efficacious. So the approval the first FDA approval for trastuzumab was in combination with chemotherapy. So now we're at a point where we're trying to look at what agents we can combine. And this has to be done in a clinical trial setting in order to investigate whether we can combine several different targeted agents with or without chemotherapy. The clinical trials that we're initiating here are with chemotherapy, first to see if we can have an added benefit over standard best treatment chemotherapy. And at some point, I hope that we will be able to combine some of these treatment approaches without having chemotherapy, but we're not there yet with breast cancer either. The question really is when to use MRI in what patient population, in what setting. At this point, we have trials that have looked at these high-risk patients, and we have real indication that MRI is helpful in these gene carriers. And so we know that that's established, and the use in that clinical setting is clearly indicated. The idea of false positives doesn't sound so bad until you've actually had to go through several biopsies that were unnecessary. And when you look at the data, in some cases we have diagnosis by mammography and not by MRI, and yet, and we see the reverse. So, you know, I can show you some cases where we diagnosed it by MRI, but these are anecdotal cases, and until we have established, from clinical trials, established use in women who are not carriers that we know have this 60 to 85% risk of developing breast cancer, then I think it's not necessarily going to be standard of care until we've really sorted that question out. And that's what these trials are looking at, and some of the new techniques. And I think that the work that Dr. Daniels is doing is really bringing this technology to a point where it's better. You know, if we can be sure that we're picking up breast cancers better than mammography in all comers, then at that point I think it will be used more routinely. So that's pretty impressive. So the question is patient with HER2/neu positive metastatic breast cancer, so advanced breast cancer, who has been on trastuzumab for 5 years? Yes. For 5 years, who has had no evidence of disease recurrence. When to stop? That is a very good question. I don't think that we know exactly when to stop. 5 years is about as excessive as I've heard Herceptin used or trastuzumab used. Dr. Stockdale, who is one of our other medical oncologists, is in the audience here. Have you ever seen 5 years of trastuzumab? So that's a long time. Most medical oncologists would stop by about a year. So with the vaccine approaches, they're still in clinical trials. So we definitely don't have an answer to that. I think it's an exciting area of research. And like any other vaccine approach, you generally need to generate an immune response with multiple vaccinations and boost, and you will have memory in your immune responses, meaning that your immune system will have memory for a long time, but reboosting would probably be necessary. The question is whether or not the cancer cells are smart enough to find mechanisms of resistance. I think that from the preclinical studies and the animal studies that we often do see that the tumors will initially respond and then fail to respond, and this is probably why the combination with other agents is necessary. I hope that with ongoing research we'll be able to understand how they do that, to be able to predict that and to know how to treat the tumor with more than one targeted agent to prevent it. Thank you.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.